Welcome to the first episode of our ISELP podcast, where we're going to explore the evolving new world of sports medicine, locomotor pathology. I'm Ken Allen. I'm President and Executive Director of ISELP, and I'm going to be your host as we embark on this exciting new journey. This podcast is part of our mission in ISELP to bring contemporary new knowledge and clinical insight to veterinarians and professionals around the world. Whether you're joining us from a clinic, a classroom, out in the field listening to this on your truck, which we hope some of you are, each month we will feature some of the top minds in the profession. We'll talk about case studies, we'll discuss emerging techniques and technologies that are shaping and changing the way we do equine medicine. Today I'm honored to be joined by Dr. Kurt Selberg, a board-certified radiologist, international speaker, and a familiar face to many of you at ISELP events. We're going to be diving into diagnostic imaging, how it's evolving and changing, and what it means for you as practitioners as you're trying to solve difficult cases in the real world. Let's get started. All right, as we open this podcast, it's been a thing that we've talked about within ISELP and doing for some time now, and I have to give credit to one of our ISELP members, Dr. Jackie Christikos. And Jackie is the one who suggested it, and she said we need something to listen to that is going to teach us something about sports medicine while we're driving around in our truck. And that's what we're going to attempt to do. We're also eager to hear feedback, comments, questions from you as you listen to this and ways that we can improve it. One of the best ways that we can improve this podcast is by having interesting guests. And we have that today. And we're looking forward to working with Kurt Selberg, who many of you know within ISELP because he's one of our primary speakers, along with Professor Denois and Eric Bergman. So we're looking into how we go further and deeper into these questions of technology, lameness approaches, locomotor pathology, and what we do as we're going forward trying to figure this out, that challenging case that's been bugging you and that you wake up at 5:30 thinking about instead of nicely sleeping until you're supposed to get up. So we're going to talk about that, and we're joined again by my friend Kurt Selberg. Kurt, welcome, number one.
Thank you. Good to be here.
And I can't think of anybody better for our inaugural podcast than Kurt. And Kurt, you know, you've had an interesting journey getting here. And so tell us a little bit about, now you're a Washington State grad, correct?
Yep. Before I went to vet school, I actually had a master's degree in molecular and cell biology. I had a different trajectory that I was thinking about, and about halfway through that, I said, you know, I think I much prefer working with the animals. At the time, it was, you know, some research animals and dairy cows, but I much preferred the animal side to it than sitting in the lab on the bench and then writing grants. So I went to vet school at Washington State, and then after Washington State, I went to this place out in Virginia.
Yeah, now let me stop you here. Now, this is hard for Kurt because he had a very traumatic year after he graduated from vet school. So, and he came and joined us as an intern. So tell us about that.
Yeah, so as the intern here, it's actually quite it's a small plug, I guess, for VEI to come out and be an intern, but it's a pretty cool environment coming out here, and it was actually what put me on the path of ISELP a little bit. And so when just in the infancy, and in 2007, I think is when I started this, all of the videos were on these DVDs. And so I started the process of making them into digitalized so I could just put them on a iPad or iPod. At the time, I was, I think, just putting them on the phone, the first generations of the phone, or putting them on your computer. And I started watching all of the old ISELP videos. Whenever I'd come in the morning, I'd watch them. And that really put me, I think, light years ahead of anything else because of the anatomy, the refresher of anatomy, and not only that, the new anatomy that we weren't necessarily delving into at the time. And it made me pretty excited, especially as you start to think about imaging, is essentially an anatomist just looking at image type of it. And so, going through this whole thing at the time, Professor Denois, man, it was actually revolutionary for me to try to put me on this path. And I had kind of vacillated between being an equine surgeon and being a radiologist when I was going through, and definitely pushed me towards being a radiologist, seeing how much imaging was involved with sports medicine. And I liked that puzzle piece a bit. Was looking at the imaging and trying to put everything together. It can be frustrating and rewarding at the same time, but I think that's just the nature of the horse. Can be frustrating and amazing at the same time, and it keeps us coming back, though.
And you are our only intern. I've told this to many interns after you, and when I get a new fellow in, and that you are the only one who actually went through all of the ISELP modules in the first year. And you can always tell the ones who actually do that, because it's like they do their descriptors of pathology almost with a French accent.
Yeah, no, it's good to have that French accent. It's a little bit more. It's a softer delivery to the bodies.
Professor Denois taught us all. So. Yeah. Now, after you finished your internship with us, where did you go after that?
So I sent out to go to Colorado State to do. It was a generalized radiology residency. Nowadays, we've, with the help of several key radiologists, made another college or subspecialty within the College of Veterinary Radiology, and that is the equine specialist. And so went back and did my general radiology at Colorado State. And at the time, Colorado State, they were busy with horses. They had a phenomenal set of faculty members that were associated with horses and did some of the first research on putting horses into the magnet. And it was a really cool experience to be out at that time. Not only that, there's a couple of things that have kind of helped out along the way, but coming from from Dr. Allen's, where I had digital radiography, the first unit in veterinary medicine, I might add,
right.
Have that, and then I went back to Colorado State, where I'm still dipping films in tanks. It's a nice kind of transition. So there's a lot of things, at least in terms of physics-wise, that you still hold in a principle, and you can kind of troubleshoot some of that stuff. So it's nice to have that evolution of seeing the olds with the new and that transition and figure out what we can do.
Well, I think that's interesting point you bring up, in that I think radiologists of my generation, they considered themselves largely purist, and so give me the images, don't tell me much history. And, certainly I don't want to be involved in the clinical involvement of it. I'm just reading the x-rays or the... Yeah. And I think you're the embodiment of the newer generation of radiologists, where they want to know the history. They want to know... I think, you're unique in that, you spent that year doing clinical cases and working up lamenesses and blocking horses, and so you have the feel for what the practitioners are struggling through. And then, when you have that background, and more radiologists are doing that nowadays, where now we can kind of relate to the radiologist a bit better, and we can feel like we can call you up. Well, that was an interesting read, but it didn't really answer this question. What do you think about this? And you have the background where you can talk intelligently to us, or semi-intelligent.
Yeah, I was going to say that's not a word that's usually thrown out in my day, saying intelligent and speaking. But I would say there's a lot of that came around. One is my years here, and then even after that, and after I went to go be faculty at University of Georgia, coming back up here once a month,
right,
to work up horses for a bit of time. Was instrumental. You start to finish horse and see how it is, then to get to follow up on the horses. That makes a huge difference. And one of the things about ISELP is that ultrasound heavy experience is that when you're ultrasounding, you also get the opportunity to palpate, and you get to test then your palpation skills at the same time. And it just puts as a whole, puts everything to start to be together. You're like, oh, well, I know that whenever I palpate this, it doesn't relate back to what I see on the imaging necessarily. So you get a way better idea of what's happening with your palpation skills, being able to put the probe on and then palpate again, and then take the probe and put it other places, and as a clinician come up with a better idea of what is happening with the animal, why it's lame in that particular area, among other kind of techniques that we use, which are diagnostic anesthesia and Doppler interrogation, all those things in imaging. But the number one diagnostic tool is your hands, eyes, and brain. And I think that's really important, is putting your hands on the horse and understanding the horse more than just sitting in the dark room.
Well, and we've all had, a favorite comment I always love from a practitioner is I'm sitting there talking to them about their referral bone scan or something, and they'll go, I'm not so sure I believe that, because, a bone scan can lie to you. And you just try to get them focused a bit more, and you say, every technology, it doesn't matter what it is, has shortcomings and positive things that you can take from it.
Yep.
And it's up to you to make sure you understand those things. Your hoof testers will lie to you, because you will sit there and squeeze on the foot and you will get a reaction, and yet your blocks show you that's not where the horse is lame. Well, but sure, sort of those hoof testers. Well, it is sort of the hoof testers.
Yeah.
Hoof testers aren't lying to you.
No.
You're just making sure you're interpreting it correctly instead of incorrectly.
Yeah, exactly. The interpretation is, you can either have false positive or false negatives, and all of them lead to a limping horse still. And so you really got to focus those. And like I said, being a thorough examination and then using imaging to confirm clinical suspicion of disease, I think is all the things that embody, one, sports medicine, and two, what International Society of Equine Locomotor Pathology, kind of the mainstay in education mission, is putting everything together in a nice package, and sometimes they're not an easy package to figure out, and they're very complicated kind of in that way, but at least we have the tools to go through that, figure it out, and try to get to the correct diagnosis. And the correct diagnosis is the key, because then we can also use that for targeted treatment and also prognostic value of
exactly. That's huge, because once you finally get the diagnosis, then the next question is, okay, well, what's it going to mean to this horse? And that's ultimately what the clients want to know. They want to know the diagnosis, but then they want to know, okay, well, can you treat it? And sometimes that treatment is just rest.
Yep.
And sometimes it's other therapies. But then what they want to know is, from your experience or your conversations with experts, on what the likelihood is that horse can go on. Because, my number one client, which is my wife, that's what she wants to know with her horse. Yes, it's lame. Yes, I can treat it. Okay, what's it mean? Does that mean I need to go buy another horse? That's her first question. And then the second question is, or can we rehab this one and get it back to doing what it was doing? And so your knowledge and viewpoint on that, because particularly as you've gone down, I've continued down the clinical journey, and you've gone off on the radiologist journey, but with clinical background. And then the thing that you have the huge advantage of that we as practitioners don't have is that you're going to, on horses with cyst in P1 or P2, you're going to see now, because of the journey you're on, 10 times more of those than I'm ever going to see.
Yeah, having that caseload and then what I'd call institutional memory of what's happening, and I do this every day, is do little mini studies of going back and looking at certain areas, like is that something that is clinically relevant? Did I see that every time? And going back, but yeah, exactly. The same kind of thing.
It's huge, and when I get to pick your brain on that, it's very useful. Now, so you finished up your radiology residency, and then you went to Georgia, and were in the clinic there. And then you went back to Colorado. So tell us about that.
Yeah, so in Georgia was an amazing time, great people sitting there. It was a new hospital, and so I was there for just under 5 years and got a really cool experience to see a new hospital built, put in some new advanced imaging, kind of from the ground up, kind of take it. And in the meantime, got to come back up and do lameness work, which is, really kind of rounded out, at least for me, what feeling comfortable as a package of equine practitioner to move through it. And I would say that the newer generations, as you had said, are doing this. They're much more of a hybrid where they get to touch the horse or do something with the horse. And I think this equine diagnostic imaging certification from ACVR, as well as the European version, has really put the clinician and the diagnostic imaging on the same page, along with what I say is ISELP, which has done the same thing to the general practitioner. And now you start to see specialists coming in and doing that same kind of thing with ISELP. But so after Georgia, which was an amazing time, we started to miss the mountains a bit. And so it was a fortuitous time, because as we're thinking about how much we miss the mountains, Colorado State calls and said, hey, we want you to come interview. And so we went back out to where we were taught and had a nice interview. It went well. Obviously, I ended up there. And some of that is going back to the mountains, but also the people at Colorado State are equally as amazing and get to deal with very smart people on a daily basis. Let ideas flow back and forth, and keep each other in check, especially when, if radiologists have a propensity to potentially make stuff up, because we have a hell of an imagination, And so, sometimes the surgeon's got to come back and put us in our place. That's not that common. But it's most of the time the radiologist telling the surgeon that you might want to try something different. A small plug for radiology.
Yeah. Well, and now I correct me if I'm wrong, but I believe Colorado State just instituted a new program where on their sports medicine residents, they are having them go through the ISELP modules on the live stream.
Yeah.
And then you are teaching them the wet lab portion of that.
Yep.
And so they are all going to be able to take the ISELP certifying exam.
Yep, for sure.
And so that's kind of a new thing.
Yeah, I really like and that was kind of, I think, the brainchild of actually Dr. Contino at Colorado State. And she said, I think this might be a good idea to put these guys in ISELP, let them get that anatomy and then some of the locomotor pathology abnormalities that kind of go on, complement their training with a very adept group of clinicians at CSU. And then I'll come in and I do ultrasound. Now they did, for the longest time, we had the way our residency was set up is a 1-year ultrasound, and then they went into their 3 years of their sports med residency. With the bringing on of the new subspecialty in equine diagnostic imaging, we now have our own radiologist. So there's going to be a lot of people in the same room. So we had to move away from that. But this, putting it into the ISELP and then having a full day with my residents to focus on certain body parts, go through the descriptions, but also have that end goal of potentially being an ISELP certified member, to be, kind of, I guess, more involved in the community rather than just your own practice, but it's the community of education. And I think that's one of the values that a lot of these are coming home, is the educational value. How much you got from ISELP, but I would also like to pay it forward and give my information that I have had. And it's not just the positive information, it's the way you screw things up, I think, are equally as the learning. I've probably found at least every way to screw it up at some point. Yeah, and I've had a great mentor to show me sometimes how to do it.
Well, I'm glad you paid attention when that was happening. The other thing that's kind of new and interesting is that you've been part of, along with Dr. Bergman, on working on information for the student ISELP program. And I believe that there's going to be one of the vet schools, one of the newer ones, is going to have all of their students that are interested in equine anyway, go through that hour anatomy, pathology video that you've done, and then they are going to do a wet lab as well. And that's, I think, astounding. I mean, it's tremendous that sports medicine residents get to do this, and I can only see them benefiting them hugely. But to look back and think of you and I as students, the ability to sit there and learn the anatomy in a purposeful manner that you are going to then walk out and use on the horse, which that was always the disconnect for when I was going through it, is, you'd learn anatomy for a year, and then you'd go through a couple of years, and then finally you'd get to go to the horse and you'd try to recall the anatomy. You never really had an idea of how useful or not useful it was going to be.
Yeah.
But then you get your moment to actually put it into action on the horse. And I think to do that as a student and make that connection early is astounding.
Absolutely. I mean, absolutely. I remember so many times looking at anatomy, and I had great anatomy professors, no doubt. They knew their stuff, and they'd put out palpation stuff, like animals that we got to palpate, but I'm not sure the ability to put all of that anatomy back into the clinical portion of it by the time you get to fourth year or third year in clinics. It was a bit of it's a long time to not remember some of the little nuances of anatomy, and having this as a refresher, and honestly focusing more on what is the clinically relevant areas, that where the injuries occur, what is the other anatomy around it, the collateral injury that can occur, all of those things, like putting all that together, and then where common diseases occur and when to look for them or how to look for them. All of those things are very important, and I think that kind of comes back into this this mission statement of ISELP, of putting, again, the clinical with the imaging and mixing it all together and coming out with the benefit of the horse. Because I think we're all kind of in the same realm where we're in it for the love of the horse. Now, granted, I like what I do just as a job, but it's for the love of the horse to come back and do these things. And that's ultimately, I think, why we keep coming back to these educational values, is the love of the horse.
Well, and I think the student program is going to be really key as we go forward, and it's great to introduce them to ISELP, and that's a resource for them as they go further into their career, if they want to get into that level of veterinary medicine and equine veterinary medicine. But I think really the program that you're doing and making it relevant early to them in their career is gigantic.
I totally agree. One of the things that I hear from clinicians as they come out in the world, they're like, well, we want them, we expect them to do some ultrasound as they come off and out of clinics. And oftentimes we do have labs where we do ultrasounds. It's just, as we know, ultrasound is repetition. You got to get muscle memory. You got to understand the size, the shape, the margin, and having this circle back around at this level, the student level, just puts them that much further against the people that potentially aren't doing this and they're ready to go a little bit more than having not done it. And so these labs are paramount, because as you go through it, there are clinicians that are going to be teaching the labs, and like, see this tendon, see how the shape has changed. This is a significant lesion. Although it seems subtle, that is a significant lesion, and having that immediate feedback of where common disease processes occur and what the prognoses are huge for an early practitioner. And this puts them a leg ahead, I would say, without a doubt, is having these small lectures and then having these hands-on kind of labs for them to ultrasound. And that's one of the areas that we, in vet schools, we are not giving enough time to, but be honest, we hit the ground running as fast as we can, and we just run out of time, to be honest.
Well, and you know, the thing that, and you've heard me say this to interns, fellows, and people at ISELP courses that we're training, but the hardest thing to do in an ultrasound exam is to image the suspected structure and be able to put the probe down and say, no, that's normal.
Yep.
And because there's always going to be artifacts and a million different things that your mind can latch onto and say, oh, that's it.
Yep.
But if you know it well enough, just like you say, your mental muscle memory, looking at that structure, imaging that structure, looking at it and saying, no, that's normal. Yep. So we got to go on and figure out what the problem is, because that's not it.
Yeah.
And that is when you can start feeling like you're good as an ultrasonographer.
Yeah, the hardest thing to call is normal. And especially when the horse is lame and it blocked the area, and then you're ultrasounding, you know that something has to be wrong in there. So any little thing, and I've absolutely been guilty of this, where you're just grasping at straws, only to now have an evolution later, is that a negative scan is a positive. We know now what it's not.
Right.
And that's really good information. Now we need to figure out what it is, and then we start to go into what's the next best step to try to figure these things out. Sometimes it's based on availability, right? So it'll be ultrasound radiographs, and the nearest clinic only has a nuke scan, so doing a focused nuke exam on these areas, I think, can be incredibly helpful to put it along with the anatomic anatomy, right? It'll draw you in, it'll actually get you a little bit kind of looking at those radiographs a little bit more, because you'll see a hot, like an abnormal radiotracer in the bone, and then you put them on the radiographs and you're like, okay, and then you scrutinize the radiographs a little bit more. Or you move on to an advanced imaging, and then you got to figure out what the pros and cons are for each one of those, and that's MR or CT right now, or even PET, all of those things, and what we're trying to look for, what is our clinical suspicion of disease, and those are all the questions that we go through in ISELP every day. Kind of is, what is the next diagnostic step? What is the prognosis?
Well, and that's, I'll do a plug here for a moment on ISELP's 3D imaging course, which we started 2 years ago, and you run that, and it has been a phenomenal course. I mean, to quote one of my associates that went up there, and he came back and I said, what did you think of the 3D imaging course? And he goes, that was life-changing. And, you know, we've just recently brought CT scanning into our practice now. And, you know, I can tell you just 2 months in that I can sit here and say, oh my gosh, three-dimensional imaging is there was a piece of the puzzle I didn't even know I was missing that much, but I was. And, certainly MR supplemented that over the years, and MR has tremendous benefits, but it also has some shortcomings.
Yeah.
And CT can help supplement that. And like you say, both bone scan and PET have roles to play in that. And sometimes it takes all of that to figure out what the heck is wrong with this case.
Yeah, I totally agree. That is one of the things. Like, we definitely know the strengths of certain imaging modalities. We know the weaknesses of imaging modalities, and understanding those, and when the best case scenario to do that, whatever imaging that is really important to try to get to the answer. But again, if you have advanced imaging and it's a negative scan, that actually is good news. Most of the time we know what it's potentially not. We don't know exactly what it is, so then we have to keep going. But I would say that CT has been, especially the standing CT, has been a huge game changer in veterinary medicine as it stands. The amount of horses to put through, and then, obviously Hallmark, or not Hallmark, but MRI and Hallmark is one of our huge standing portions. Yeah. And so the ability to go back and look at a standing CT and a standing MR, and then compare those, and then we get a better idea of what is happening with a lot of those horses, and it helps us choose which modality we would go to first. Just comparing them one side by side kind of thing, and there's plenty of practices that have that ability. But not always do we get the opportunity to do it because of the finances. But when we do get to do it, there's such a huge education that happens when we get to compare those imaging modalities of what's happening.
I agree. Well, now, but before we wrap this up, we wanted to do, so you get to ask a question of me that maybe you may know the answer to, but our audience won't. And then I get to do one to you.
Oh boy, that sounds like a danger zone.
Okay, you want me to go first, or are you going to go first?
I'll go first.
Okay.
So as you've had such an interesting path yourself, I think, and you've been at the forefront of some imaging modalities. What is your favorite imaging modality as you've gone through it and brought certain things into the market? What has been your favorite and most game-changing modality?
Well, that's a really good question. And like you say, I was lucky enough to be one of the first people to start doing musculoskeletal imaging back in the mid-'80s. And had great mentors to help me with that, and then eventually ran into Jean-Marie Denois, and he opened my eyes to a lot of it. So ultrasound was a very slow evolving path for me because I started it so early. I just like I was saying, the CT has just blown me away. Yeah. And Dr. Bob Twardock back in the early 90s started me on my path. I went skiing, and the Allen family is evidently genetically non-predisposed to skiing. And I managed to destroy my knee. My sister's broken her femur. My kid hit his head. So, we're not meant to ski. Evidently the Selbergs are, but not the Allens. And and when I had that time, I went and I sat on literally showed up on Bob Twardock's at University of Illinois porch and said, "Will you teach me nuclear medicine?" And he was very grateful. So then that was a ramping up, and that was the second gamma camera in the United States. Yep. It wasn't in a university. But the one that I'd have to say made the big difference was digital radiology. And that one, we were, like you say, we were the first one in veterinary medicine in the world to have that machine. And that was a person I'd known well, and he'd been looking for a machine, and he finally calls me up and he says, hey, I think I got one. And I said, well, okay, tell me about it. And he says, yeah, but they won't sell it to you. And I said, why? They said, because they know veterinarians, and they say they're a pain in the ass and they're going to be on the phone to them every day, and they don't want that. So they said they'll sell it to me if I prep it, do the technical stuff, and you do the veterinary stuff. And I said, okay, fair enough, we'll do that. And so I paid an astronomical amount of money in those days, and finally got it, put it together, started, and then I sent a radiology study of a stifle to a colleague of mine. And he and I had been consulting for years, and he was a mentor of yours as well. And so I sent it to him, and this is Bob Schneider, and I said, well, Bob, what do you think about that stifle? And he says, Kent, I have no clue. I'm seeing stuff in there I have never seen before.
Yeah.
And that was digital radiology when it started back in the day. It blew us away. I mean, it was game changing. And of course now it's like you say, you know, we're all doing that, and we can put nuke with it, and you know, you can fuse images and technology, and we've got CT and MR. But back then, when one of our primary tools was just the radiographs we could take, that just blew me away.
Yeah, for sure. Especially as I told you, my journey of going from one to another, like the dipped films versus the digital radiography, the contrast, the ability to have a more accurate exposure over a wider variety, meaning forgiving, and then being able to zoom and change the contrast is such an amazing scenario. And I too like radiographs. I think it's as I have evolved, I moved away from radiographs and was much more focused on MR and then now CT. And now I realize I love those. I'm gravitating back to the radiographs because this advanced imaging is changing my interpretation of radiographs as well. And it's an evolution every day of learning.
Yeah. Okay, well, now a lot of the audience won't know this, but part of your path, as you've been set on this, came from your childhood because your father was a farrier.
Yeah.
And so, and when you showed up, you know, and Bob Schneider had sent you to me to interview, and you only had a day to come interview. And so we talked, but we talked about that, and it struck me, your knowledge of farrier and how that works with locomotor pathology, and a radiologist understanding the foot is a unique thing. So tell me how that, having a dad who made you pay attention to the foot, changed your journey.
Yeah, absolutely. You know, and sometimes you don't really realize it until you're in the thick of it, and then you remember back the things that, as you're sitting out there pounding on steel on an anvil, and looking at the bottom of the foot, or looking from the foot from a couple yards away while you're shaping it to remember it. But what it has done is essentially made me understand some of the biomechanics, what we're going to do, and just being able to look at the foot, and then having the backup knowledge of what I looked at over time. Let's take an example of a keratoma. There's plenty of horses that you look in the bottom, you can see a little nodule right around the white line disease, and the horses aren't lame, but they've got a keratoma sitting there, or keratin hypertrophy. For a while there was this huge push on the keratomas. As you and I know, we've got a sordid history of keratomas. Looking at them, you realize that some horses just sit there with a keratoma and they never become clinical for them, and nobody totally knows about it because the horse never comes lame. But you, as a sitting there as a farrier's son, looking at the bottom of the feet, you definitely kind of understand certain disease processes as you look through it. Like, okay, well, that's what's happening there. And then realize, as you said, hoof testers lie to you. And I routinely on that thing, I'm like, well, on an MRI or even on a CT, you'll see a big abscess and you'll see bony inflammation. And they're like, there's no way that's an abscess. It's been going on for 10 weeks and the horse isn't hoof tester sensitive. And I said, that is the one thing that you'd be surprising how many horses don't have hoof tester positivity on abscessation, and it then moves away from your thought. But as you go through it, it's definitely an evolution of trying to understand certain things of the way the horses present, and like I said, being a farrier's son, you just get to look at the horse's foot and then figure out the shoeing. And I was moving through. One of the things that my dad always taught me was Occam's razor, which is the simplest solution is the best solution when it comes to shoeing. Now, granted, there's definitely people out there that I probably shouldn't overstep because they're much more familiar and better at the shoeing. But one of those things, just keep it simple, stupid, and that has really shaped the way I address horses in the foot anyway. And not only that, it helps to look at the foot and be like, we can probably do some help with that. But it's absolutely shaped what I'm doing. In fact, one of the pushing agents for me to go into veterinary medicine is I was out shaping a shoe for my dad, and I think I was in college, like mid-college, and I was shaping a shoe for my dad, and he's over there underneath the horse for a little bit of time, and he's over there longer than he usually is, and then he walks back over and he looks at me from about 10 feet away, and he goes, "Son, I don't care what you do with your life, as long as your head is not below your ass." And I said, fair enough. I can do this.
And you have accomplished that.
I did. I feel like I compare. So that was what pushed me into veterinary medicine.
Well, I don't know how to top that. I mean, we may have to do a whole podcast sometime of things our fathers taught us.
Oh, geez, there's a whole bunch of them for sure. In fact, I probably use some of the things that your dad taught quite frequently.
All right. Well, we're going to wrap this one up, and I really enjoyed it, Kurt. Thank you. And
thank you.
And we're looking forward to having more of these podcasts and more information. And we'll look forward to you being on this journey with us. So thank you from ISELP, and see you next time.